opportunity to share my experiences regarding the rural health services in India. So am I audible?
Yes, you are audible. You are
Yes.
audible.
So I started my journey in the Assam Medical College as a MBBS student in 2008 and completed it in 2013. After completion, I was appointed as a medical officer in State Dispensary of Golaghat district of the Assam as a compulsory 1-year posting. After that, after completion of 1-year services in State Dispensary, I joined as a medical officer in the tea garden community under the Assam Company India Limited. After that, I completed my post-graduation in 2017 to 20, and I returned back to my home state, that is Bihar, and presently working as senior resident. And sidewise, I also running my OPD for my villagers, especially for villagers, free of cost, without charge. So coming to the rural services, yeah, it is actually after completion of MBBS, it was very adventurous. The first place, that is in Golaghat, it covers around 10,000 population without proper infrastructure. In tea garden community, that was also an adventurous job where the many problems were there, especially the poverty, hygiene maintenance, malnutrition. These problem I was facing, but at the same time, I was appreciated for the some work, and sometime I was also, some point of time also, I was attacked by a mob, which is, I think, a new normal for a doctor in the rural areas.
You had a very varied experience. You were
Yes.
working in the tea garden. You were working in the villages. There was violence on you, which
Yes.
is normal that you say. Okay, so let me just ask you. We in the medical colleges usually as postgraduate trainees, we get exposure to a lot of academics.
Yes.
हम लोग तो क्लिनिकल ट्रेनिंग भी होता है हम लोगों का, उसके बाद हम लोग को थेसिस करना पड़ता है, उसमें एक डिसर्टेशन करना पड़ता है. तो मुझे जितना दूर पता है आप हेपेटाइटिस बी वायरस के ऊपर आप काम कर रहे थे, इंडियन काउंसिल ऑफ मेडिकल रिसर्च के साथ आप कोलैबोरेट कर रहे थे, तो उस लेवल के काम आप कर रहे थे. उसके बाद जब आप गांव में जाते हो, व्हेन यू गो टू द विलेजेस, व्हेन यू सी द ग्राउंड रियलिटी, तो जो आप सीखते हो मेडिकल कॉलेजेस में, जो चीज आपको मतलब एडवांस मेडिकल टेक्निक्स रिसर्च जो सीखने को मिलता है, क्या वो सही तरीके से आप अप्लाई कर पाते हो गांव में जाके? आपका एक्सपीरियंस क्या रहा है इस हिस्से में?
At the ground level, actually my thesis topic was regulatory T cell expression in hepatitis B virus. So it was a molecular study, and I was conducting it in collaboration with ICMR. So it is basically a molecular study, but at the periphery or the ground level, we don't have such laboratory or advanced technology to know the to know about these cells. And these are the very molecular cells. Apart from hepatitis B, these regulatory T cells also help in pathogenesis of IBD, that is immunosuppressor cell. But during the thesis, apart from these molecular level, we also came to know about the different stages of the hepatitis B, different treatment modality when they need the treatment, which most of the people are confused at the time. Apart from that, approach to a patient with hepatitis B in pregnant, approach to a patient in adult. So these things really very helpful in day-to-day practice and the clinical practice. Because we all know acute hepatitis virus or hepatitis B virus, it resolves by in 95% cases, it resolves by itself. Only 5%, depending on the stages, it needs treatment. So that molecular part, it is not very significant clinical approach in periphery or the ground level, but during the thesis, whatever I have learned about the hepatitis B in the clinical aspect, that is very useful to us.
So regarding this clinical aspect that you are saying, obviously the college that from which you have passed, Assam Medical College, that has a long history of clinical medicine.
Yes.
So, but what we are seeing in medical education in the recent times is a decline in clinical medicine. It is more of investigative and laboratory-based medicine. Any patient comes, the straight way, the doctor would prescribe you go for an ultrasound, go for a CT scan. Sometimes doctors don't even bother touching the patient. That is the ground reality today. So, what has been your experience in this regard? Do you think clinical medicine is still relevant in today's time?
I will like to elaborate one incident during my second year of the post graduation or the early part of the third year. When I was in the ward, my guide professor A.K. Das sir was discussing something and asking about the patient. The patient came with edema, anasarca, raised blood pressure, decreased urine output, and she was previously diagnosed with SLE. So he was asking me, what do you think? So I told him that it may be a case of lupus nephritis. So his next question was, what is your approach? What do you want to do in this patient? And have you done it or not? It was early morning now around, and patient was admitted during the evening shift. So I told him I would like to start methylprednisolone pulse therapy, but he scolded me because you have delayed the treatment based on your clinical judgment. So what is the use of your clinical judgment? It would have been started at the time of admission or once you have made the diagnosis. So this is the beauty of this is just an example. There are a lot of examples when we used to start the treatment for the betterment of the patient based on our clinical judgment. But nowadays everything is available, and doctors are not, or students are not much interested in examining the patient, not even by touching pulses or abdominal examination or whatever. So somehow they are lacking somewhere. They are missing the beauty of the medicine or the clinical practice. So by any means or whatever means, the clinical experience can never be replaced. So this is my opinion regarding the clinical practice.
Thank you. Next, I would like to ask you that during your journey in the rural sector, what are some of the most significant challenges that you have faced, or what are the challenges that you face while practicing in the village, in the rural area?
In the rural area, it actually depends upon area to area. Like most important problem while I was facing was the socio-economic status of the patient, because our primary healthcare center or infrastructure in the government setup is very poor and very poor. So socio-economic status, when a patient is coming to you based on your clinical judgment, even if you prescribe a minimum test like hemoglobin for confirmation of your diagnosis or urine RE, they are affordable to that. The next step is, even for confirmation of diagnosis, if you are prescribing some costly test like TROP-T for detection of the myocardial infarction, which is life-saving procedure. So it costs in the periphery, it costs around 1200 to 1500. So next step or next thing that came to in my mind, whenever I am prescribing these tests, whether patient will, if I am diagnosing this patient as myocardial infarction, next step, whether he will be able to purchase the medicine or not. So ultimately, we have to save the life and we have to start the treatment. So socioeconomic status is the very it plays a very significant role in clinical practice, and it is a barrier to the for providing the healthcare services in the ground level. Second is, even if we have diagnosed the simple cases like anemia or like a stroke, we have to refer the patient because we don't have blood bank facility or any CT scan facility at the grassroots level to diagnose and start the antihypertensive or thrombolysis in the periphery.
But then, Dr. Rajnish, I would like to comment here that the government of our country is proudly proclaiming that the GDP rate of the country is touching 8%, and India will be a 5 trillion economy. But what you are saying is totally different. So, what exactly to believe here?
This is actually a ground level thing, and one who is working at the ground level will definitely say government is proclaiming 8% GDP with 80 crore of the population. He is on 5 kg ration for their survival, and we are proclaiming we are the third largest economy of the world, and with this type of infrastructure especially in the health sector. So these both are the contrasting thing, and ground level reality is different, very different thing. Whatever the top level authorities are saying, it is very different thing.
So how we also know that there is sometimes, for example, in recent times, now it has come to news that there is acute shortage of TB medicines for TB, tuberculosis throughout the country. So how do you deal with the shortage of medicines? Because it is difficult for me to imagine that in a village, if someone comes diagnosed with pulmonary tuberculosis, who is on treatment maybe for 1 month, 2 months, and then comes to you and you say that we don't have any medications. So how do you manage this kind of situations at the ground level?
At the ground level, sometimes I can remember my incidents during the tea garden posting, where though hospital was under the company, like the country, the status of the hospital was the same. They were benefiting from the labors, but they were spending very minimal. I don't think 1% of their budget was spending on the healthcare services. So there was always shortage of or crisis of the essential medicines like antibiotics or painkiller or paracetamol. It was very difficult. At that time, I used to roam from government sector from this district to that district and asking the officer in charge of CSC, sometimes joint director, to somehow manage the medicine. And they are managing only for 1 to 2 days or 3 days. Then they will ask, we'll see it later. So this is very different thing at the ground level.
Yeah, but you roamed from one district to another district medical officer asking for TB medicines, but not every doctor will do that.
Yes.
Right. So maybe you are unique in that sense that for your patients you could do that kind of work, but it's really almost next to impossible to imagine how the patients will get the medications with this kind of.
That's why we have entered into MDR era. Pulmonary TB is now a new normal thing. Because of this strategy of the patient, supply interruption or whatever things, poor patient compliance, lack of awareness, we have entered into every diabetes patient is not a normal patient. They are either MDR TB or SDR TB.
That is multi-drug resistance or extensively drug resistance.
Yes.
And even after getting multi-drug resistance, the medication changes, as far as I know, because there are other medications. And even if those medications are in shortage, then we don't have any answer really to this kind of.
So this is a vicious cycle.
Yeah.
In the world, the TB drug medicine will keep on changing based on the status of the tuberculosis, but in the availability, there will be always the supply unless the government has some political willpower to improve the healthcare.
So I was just listening to you. I was remembering what I studied in my SPM, preventive medicine. there was one committee called Bhore Committee in 1946 by Sir Joseph Bhore. The committee said that the health of the people should be the responsibility of the government from womb to tomb. That was mentioned there, from birth till death. That means so. And even in the 1978, the Alma Ata Declaration, they said that health for all by 2000 AD. But listening to you, it is pretty apparent that the government has withdrawn totally from health services. And the other point is that there is rampant privatization, commercialization of healthcare in this health sector. So how does this affect health services, especially in the rural sector?
Since whenever a student enter in a medical college, MBBS, the whole system is divided into two parts. For showing the public that we are doing something for them, government is opening every new day a new medical college in every district. Along with that, they are also giving recognition. NMC is also giving recognition to the private medical college. So in a district, you have a government medical college and a private medical college. So the students who will qualify for the NEET exam will go to the government medical college, and those who are affordable or belong to well-to-do family will get, and not selected in the NEET examination, they will go into the private medical college. So after examination, after passing, during the course, there is severe shortage of the specialist doctor of the concern. Like I have heard in one of the medical college, government medical college, forensic medicine class is taken by the ENT and surgery people. This is the thing. So how we are training these people in the government setup? There is not proper training, no proper training of these people. And these people in the government medical, after passing MBBS, they have to do compulsory bond posting in the periphery or rural area. So if we are not training them, then how will they cope with this, or how will they manage a periphery or PSC or CSC? But what we are doing in the government medical college, even though there is good technology is there, they are advanced in all things, but they don't have any compulsory bond posting. So this is two different things. Half of the people we are preparing for the rural setup, half of the we are giving corporate sector. And after spending crores of money, no one will like to go into the resource deprived areas with a scarcity of water and electricity. So these private medical college people, again, they will go for their post-graduation, and after post-graduation or super specialty, they will join the corporate. And the rest of the people in the government setup, they hardly 10 or 5% people will go to the periphery. Everyone will go and join the corporate. So commercialization and corporatization, these are two things. After over flooding in the metro city, like Delhi or Kolkata or whatever the important city in a state, they are targeting the district headquarters of each and every state. So they have a marketing team. They will their marketing team will contact Jhola Chap or quakes in the periphery, drivers at the PSC level or CSC level, and ASA workers. So whenever a patient is being referred from the PSC and the CHC or anywhere, they are directly, their marketing team, they are in contact with the marketing team of the corporate hospital, and they are taking the patient to this corporate hospital. In turn, they are providing a huge amount of money or bribe to these people like Jhola Chaps or CSC or ASA workers. So this is nothing but commercialization or corporatization, whatever. They are, in good sense, they are doing something, but they are also polluting the ground level healthcare services, directly or indirectly. People have to pay for that. This is the harsh and very bitter reality at the ground level.
So, like two things I was thinking when you were saying about all this. One thing that comes to my mind was that maybe last year or before that, maybe 2 years back, one radiologist seat in a private medical college, maybe in Gujarat, that went for 14 crore rupees.
Yes.
Now, just as listening to you, so after getting admitted to the college, the student will pass out with the MD degree in radiology. Definitely, that student will not have any appetite for humanitarian service, right?
Yes.
That is,
Uh,
yeah.
After spending crores of rupees during the MBBS post graduation, no one will talk about ethics, patient priority, or at the ground level to service of the humanity or the human being at the ground level.
So ultimately, what happens is that medical ethics is totally destroyed.
Totally destroyed.
So, and what we have studied is that medicine is a different kind of a science and art altogether. It is the
Yes.
ethics in medicine that has helped in developing medical science to the level that we are practicing today.
Yes. I still
So-
remember during our MBBS days, from third semester onward, we were posted in the wards, not only to examine the patient. Our professor used to teach us how to talk with a patient, how to dress yourself, or how to uh, present yourself to a patient. And these are, I think, ethical things. Patient priority was at the top. So after spending crores, no one will talk softly to a patient. The only target is to how to make a money. The entire corporate system and commercial system is targeting at the money, nothing else. And on the top of that government is enlisting few corporate hospital in the Ayushman Bharat. So in spite of enlisting the corporate hospital, if that amount of money, like 5 lakh rupees per family or per individual, if they are spending at the periphery for the development of the infrastructure like 24-hour ECG services, 24-hour CT scan, X-ray, or blood investigation, 24 hours, 24 hours and doctors on duty. So these referred patient will be very less, and they will be more benefited, I think, in spite of, and the facility nowadays available at the ground level under the, none of them are covering the Ayushman Bharat card.
Yeah. So yeah, the other thing that comes to my mind was that you are speaking about a nexus or a very bad network that is operating at the
Yes.
corporate level from the villages, what you call Zola Chap or brokers, or in other places called dalals. They are doing all kind of nefarious things, referring patients. And along with that, the other thing that you mentioned was about insurance. Now, the government just yesterday, the Honorable Prime Minister came to the state of Odisha today. He was saying that Odisha government has not included Ayushman Bharat, and that is why the people of Odisha are suffering. He has made this statement. Equally, in the state of Odisha, the Honorable Chief Minister, he has introduced two kinds of health cards. That is called the Biju card and the Nabin card. These cards are there. So, but listening from your talk, it is pretty apparent that the only beneficiary of these insurance schemes are the corporate, not the people in reality. What is the situation in Bihar? We would like to know that from you.
Bihar, people, hospital are getting enlisted, corporate hospital are getting enlisted under Ayushman Bharat. Okay. And the target of the hospital is the Ayushman Bharat card rather than the patient cure. Somehow they want to spend maximum money from that card, and rather than then at last they will refer the patient to some other hospital. So ultimate victim is patient. Whatever is the either Ayushman Bharat card or whatever is running in the name of insurance in the country, ultimate victim is patient.
Yeah. And the one other thing that comes to my mind, which you had said in the beginning of your discussion, that you are also the victim of violence on doctors or other healthcare professionals. Now, these incidents of violence are increasing day by day.
Yes.
What do you think actually? Where is the root cause of the problem regarding this? Or is it also linked to these kind of problems that we are discussing?
At the ground level, there are two things. You may be an outsider for the common population. Like I was in the outsider. I was outsider in Assam while I was posted as a medical officer because of the cultural and the language barrier. But I tried my best to learn the Assamese language. Tried to talk in local language. And in community, there are two types of people. One who will accept you that yes, he is giving good services. And one group of the people are the Jhola Chhap, quacks, or politically motivated people who will going to create chaos or ruckus in hospital or wherever you are uh, residing. So this group of people, whenever you are giving service to a common people, they are ultimately their financial services or their practices are going to hamper because of availability of doctor. So they try to harm. Same thing happened to me when I was attacked by the mob. I did one normal vaginal delivery and it came out to be a retained placenta. I referred the patient at the same time, and nearby medical college was only 1.5 hour or 2 hours apart. But instead of going to the medical college or tertiary center, they went to a local Jhola Chhap. He kept the patient whole night. Patient, there was a massive bleeding or severe bleeding, and by the time in the morning 6 p.m. 6 a.m. when she reached the hospital, she was collapsed, and all blame came to me. So we have to deal this type of people, and root cause is not always doctor. Sometimes it may be miscommunication, or sometimes the behavior of the doctor may be the cause, because people are getting money minded, and there is also a case of negligence from our side also. But maximum these type of people in the community, uh, jhola chhap or politically motivated people, these are very dangerous to us, and because of them, day by day incidents of attack on doctors are increasing.
Also, the fact that you mentioned that the government is enlisting corporate hospitals under insurance schemes and doing this. Instead of that, you said that the government can provide funds or can help develop the public healthcare system, rural healthcare system. I think that is also going to reduce this incidence of violence if that is done, because when a patient or a patient's family member dies, at that moment, he or she or their family members, they see the doctor in front of them. And when there is an outburst of emotion, they feel that the doctor has not done enough, and it is the lack of infrastructure also which is to blame.
Yes.
So I
Yes.
think the overall thing that you were saying about development of infrastructure, that
Yes.
can also, I think, help reduce this violence.
I would also like to share two incidents, which one of them is very personal incidents, and which has impact a lot to serve the at the ground level. One of my sister-in-law, she was diagnosed with placenta previa during the pregnancy time. Uh, she started bleeding at around 12 a.m. in the night, and to push a Trenexa injection for stopping bleeding, it took around 4 to 5 hours. Till that, till that time, she kept on bleeding. This is the this happens to me, and this happens to my family members. And uh, good
So
thing is that
they could not manage, they could not manage one tranostat injection for 4 to 5 hours. It was
for
not able.
4 to 5 hours during night time, during
She
the emergency
continued to
period.
bleed. She
This
continued
is,
to.
yeah, this is the status of the infrastructure. And another incident, while one patient was diagnosed with abdominal TB, she got somehow admitted in Ayushman enlisted hospital in nearby district hospital, district town, and she, apart from uh, apart from Ayushman Bharat card, they have also had to pay around 1 lakh rupees. After that, she was referred to a tertiary care center.
In addition to exhausting the Ayushman card value of money, they spent an additional 1 lakh rupees.
1 lakh rupees.
So, this is just the election time in the country. A new government will be forming very soon, and two things in the country: healthcare and education. They say that these are the two pillars of a modern, civilized, democratic society. But political parties of different colors, we are seeing them daily, day in and day out, giving very loud speeches, but nowhere in their speeches education or health has any place. There is only mudslinging, only accusations of corruption, ED, CBI, all these things. So unless things change at the policy level, I think it is the millions of people in the country whose lives are at stake right now.
Yes, definitely.
Also, ourselves also, because we are also part of this society.
Yes.
You gave your own example, which is a very sad example.
Yes.
So it has been very nice discussing with you all these things. You told me that you had duty from 10 p.m. It's 9:40 right now. We have here in our discussion, we have Dr. Anshuman Mitra. He is Secretary of Medical Service Center, All India Committee. So, Dr. Anshuman, if you are listening, can you just give your viewpoints on this discussion that we had with Dr. Rajnish, if you are there? I think you are not audible, Dr. Anshuman. You are speaking, but it's not audible.
Now is it better?
Yeah, it's better now.
Yeah, my speaker was having a problem. The points page Dr. Rajnish was putting forward in a very straightforward way. This is the bitter experience of all medicos and all people throughout the country. All the programs which are being done, whether this is Ayushman Bharat or any state level card like Biju and Naveen in Orissa and others, Shastro Sati in Bengal and some others in other states, entire thing is targeted, as Dr. Pragyan was telling, towards a fake market, not even a true market, a fake market, promoting the problems on health. So if it was that really okay to do a certain treatment, some expenditures there, to do some operation, some expenditures there, for some medicine, some expenditures there, that was actually target. That is not, because as again Dr. Pragya told, that election which is told to be which will decide the fate of the country over the next 5 years, the entire thing is that he is larger thief, I am a smaller thief. Entire thing is on corruption, various grades of corruption, various grades of corporate and commercial conversion. So basic things like health and education are totally not in focus by the major powers at play. So medicos, doctors, nurses, paramedics are always at the receiving end. People are at the receiving end. So there has to be a point of return. Like there can be a point of no return, there can be a point of return. The way which Dr. Rajnish is speaking is very evident that the basics of medical practice includes a responsibility of people's health. That I am responsible for the health of the people. I am a custodian of people's health. And it is not only by giving medicines, but also caring, promoting health, promoting prevention, working where policy is anti-science, standing for a correct scientific approach. So all that includes the role of a doctor. So these are the very realities which Dr. Rajnish, thank you very much, Dr. Rajnish, the very simple but very straightforward way you as you were putting forward. And it is a eye-opener for all the youngsters over here. We have to take a stand for
Yes.
whom we learn medicine, for whom we practice medicine. This stand is very fundamental in the approach of medical service center. We stand for right of people to health, and we deliberately take this stand. And only if we take this stand, then we can enjoy being a healthcare provider, being a custodian of people's health.
Yes.
Dr. Ashok Kumar Samanto, our founder, General Secretary, is also there in this session. Praggo.
Okay.
Sudhakar is also there.
Yeah. Dr.
Ah.
Samanta sir.
Thank you, Dr. Rajnish.
Yes, sir. Thank you.
I'll be looking forward to meeting you sometime wherever we can set up.
Yes, sir. Sure, sir.
Congrats.
Thank you, Dr. Anshuman. Dr. Ashok Samanta sir, if you are there and if you are listening, can you please put in your thoughts, because Dr. Anshuman has requested me to ask you if you are audible.
Thank you, both of you, Dr. Rajnish and Dr. Pragga. Actually, I have learned a very lot, very straight away criticizing our particular health system, and the whole thing is planned, whole insurance from center or from state level, these are planned in such a way that really to serve the TPA, third party means different insurance company who are actually mediator, and whole thing, whole monetary transaction in this way, corporate sectors, private sectors are benefited, not the people's health. In our student life, and even just after globalization, we had seen that everything free in medical colleges, in government setup, and right now the picture is just reverse, and it is the whole thing is planned for privatization.
Yes.
So health is very victim, health of the people is a very victim. So from this ground level we have to fight. That is the main thing. Thank you. I enjoyed, I am enriched. Thank you.
Thank you, sir.
Thank you, sir, for your valuable comments. So I don't want to take much of your time. If there are any questions here, then they can ask. Some medical students are there, I can see. And if anyone wants to ask any questions, they can be prompt and ask a few questions we can take. And if there are no questions, I think the discussion, he's shared his experiences very well with us. It was an enriching experience.
Dr. Panchanan Pradhan from Puri speaking.
Yes,
I don't have
yes.
I don't have any question today.
Yeah.
But I would like to express my heartfelt thanks to Dr. Rajnish for taking the social responsibility as a physician to serve the rural people where there is not enough facilities. No doubt, this noble gesture will inspire the MSc members to serve the ailing humanity in a better way. The time you have spared here will not go in vain. The great thing is, in spite of having a risk for your life, you have served the people without any fear. So hats off to you, brother.
Yes.
Thank
Thank
you.
you. Thank you, sir.
Thank you. So this much from me.
Thank you, sir, for your inspiring words. Definitely, Dr. Rajnish's experience and his words will all enrich and inspire us. So, if there are no more questions, then can I request Dr. Sangram Brahma? Dr. Sangram, are you there to please offer the vote of thanks and conclude the meeting?
Okay. Thank you, Dr. Anirban. First of all, I many thanks to Dr. Rajnish Kumar sir
Thank you,
on
sir.
behalf of MSc Odisha State Committee. Really, we are very much thankful to you for giving us the time and sharing your experience, your very practical experiences that one young medico faces in the rural area, in the health sector, the problems now that was discussed, that no medicine available in for tuberculosis in all over India, and about the insurance companies and so many topics here you have discussed about that. So hope here the young medicos and also the doctors and other health professionals of our country will be definitely enriched and will get and boost to serve the society for the humanity, work for the humanity from your experience, from your speech. So on behalf of MSc Odisha State Committee, we convey you many thanks and hope in future also you will be you will also give more time for us, and we will work together. We'll meet and we'll work together for the ailing humanity, for the for this noble profession, to uphold high the noble banner of medical ethics, and definitely we will be in touch. So again, thank you, Dr. Rajnish Kumar sir,
Thank
and
you.
also thank you, Dr. Pragya Anirban, for arranging such a nice session, conducting it very well, and making it a grand success. And also, thanks to all the participants, my students and others from MSc Odisha State Committee and also from MSc All India Committee, are important All India leaders, founder members of MSc also were present here, and also Dr. Ashok Samant, Dr. and Dr. Ansuman, Dr. Sudha Kamath, Dr. Vasudendra from various states, All India leaders who also encouraged us. So thank you all from MSc Odisha State Committee. So overall, thanks all. So now I request Dr. Pragya Anirban to conclude the session today.
Yeah, thank you, Dr. Sangram. We were really enriched by this discussion. Thank you, Dr. Rajnish. Thank you, everyone, for participating, for listening. We hope to learn more from you and work with you again in our quest to uphold medical ethics and fight for the right of people to health, because that is the ultimate thing as doctors that we are supposed to do and we can do. Thank you so much. You are late to your duty. Thank you.
Thank you.
Thank you so much.
Thank you.
Good night. Good night to all.
Good night. Good night.
Good night.